By the time we diagnose it, they're kind of like, okay, it's October, maybe Fluffy will make it to Christmas. Maybe. So we talk to the owners about the overall prognosis and let them determine the course of treatment for that patient, their overall quality of life. All right. This is why we don't want our cats to look like this. Because when this cat gets angry and the grandkids come to visit, it goes to hide under the bed for 3 days and not eat for 3 days, then he gets to come in as a yellow cat with hepatic lipidosis. Now, there is the association with our patients being overweight or obese. If you have a lean cat, even though they may start that process of developing hepatic lipidosis, they don't have as much fat to mobilize and move to their liver. So talking with our owners about managing weight in our feline patients is important because we trap cats in the house and started feeding them carbs. And they're not big exercisers, so we're going to create something like this just by not educating our clients about how we need to manage cats at home. So we want to make sure that we're having good dietary discussions with those clients so we don't have to deal with this guy, because I don't want to have to draw blood on him or place a catheter in him. And we don't have a litter box that size. I'm just saying, he's going to be in the hospital, he's got to be comfortable. He's not going to eat if he's not comfortable. So let's try to prevent the problem from happening from the beginning. All right, but we're not going to prevent every patient. So one, we need to be able to recognize it when it comes in. Two, we need to know that it's not usually a primary condition. So you might have that history of something strange happened in the household. The owner went out of town. And the pet sitter said, I didn't see the cat the entire time, but I tried to find him. And they're like, I put the food out, the cat never ate the food. All of that's going to be part of the history. Some of them will be diabetic, some of them will have pancreatitis, and maybe some of them have a neoplasia. So you just have to think about all of those things and ask questions, because usually once you start talking to people, they're like, oh yeah, we went out of town last week. And you're like, okay, cat didn't eat when she went out of town. You can never go on vacation again. All right, so get depression and lethargy. That's not a helpful clinical sign. Vomiting, diarrhea. Okay, again, kind of non-specific. Ictery cat. All right, yellow cat, yellow bag. The yellow cat is going to help us with our diagnostic process. When we palpate their abdomen, they're usually very angry. They're like, yeah, that hurts, don't touch me. We may have some signs of hepatic encephalopathy in these kitties, so we want to make sure that we're addressing those. Unfortunately, when we see that, we're like, oh, this is really bad. Let's pull Fluffy away from the tight circle of the brain. All right, so we get our history, we do good physical. I mentioned your patient's probably going to have some abdominal pain. That's not going to help us differentiate pancreatitis from hepatitis, but we're basically going to treat it the same way. They have markedly elevated alk phos. You're going to have moderately elevated ALT. If you have AST, it's going to be moderately elevated. And that may be from liver or it may be from muscle breakdown. They have elevated bilirubin in their serum and in their urine. So we know cats, bilirubinuria, that's bad. It's always abnormal. They may be hyperglycemic and they might be on the cusp of diabetes. You might have to treat them as a diabetic as well as managing their hepatic lipidosis. And if they're not icteric, we can run bile acids, but if they're icteric, we want to run blood on them. All right, so we do some rats. And we see an abdomen where we have a whole lot of fat paddage. But we also have a liver that's sticking out beyond the borders of the ribs. We go to squeeze this guy, and he goes, don't squeeze me. And he sits there and growls, and you're like, I really just need to hear if you have a murmur, dude. He's like, and then he stops and takes a breath, and you're like, boo, 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 boo. All right, no murmur, all right. So get through that process. We do, if we have ultrasound, stick the ultrasound on these patients, we see that they have hyperechoic liver. Unfortunately, you cannot differentiate a hyperechoic liver with hepatic lipidosis from a hyperechoic liver that has lymphoma, and we need to know the difference. Because if I start this patient on steroids for any reason and he's got lymphoma and I don't know it, I've probably shortened his lifespan if his owners wanted to follow real chemotherapy. So we got to make sure that we're considering those differentials. So diffusely hyperechoic, I can't see pretty much anything. I can't differentiate anything. Here, cat liver, I can see some portal vessels. I can see hepatic vessels. So I got to know the difference. So the nice bit is I can do a fine needle aspirate. Fine needle aspirate will tell me I either have hepatic vacuolization or I have lymphoma. So at least we got it quick and dirty to determine if lymphoma is present. Management. We need groceries in the cat. Now we have to be careful about putting groceries in the cat because if this has been going on long enough for them to start pushing potassium and phosphorus out of their system, then when I go to feed this cat, the food is gonna stimulate insulin release. The insulin is gonna push glucose into the cells. It's also gonna push potassium and phosphorus into the cells. If my patient is phosphorus depleted, I can actually create a hemolytic crisis in this patient. So I gotta be careful about refeeding this cat, and I need to pay attention to that phosphorus level. They're probably already gonna be potassium depleted. We're gonna add that to our IV fluids anyway, but I'm keeping a close eye on that phosphorus. If their phosphorus is kind of like mid-range or low in normal, I need to make sure that I'm adding potassium phosphate to their fluids. We kind of use this general rule of adding B complex to the fluids, yellow cat, yellow bag. We just want to provide them with additional B vitamins in order to give them those cofactors that the liver needs to carry out its normal function. Some people still consider it voodoo, but it makes me feel better. Some of your patients may need an additional nutritional support, so you can give them glucose, but if they're hyperglycemic, then you got to treat them. Then you may end up in the process of treating them like a diabetic. They may be a transient diabetic, but if they're significantly hyperglycemic, you're going to have to treat that component while they're in the hospital. So I'll post some information about refeeding syndrome so that you guys can understand this process a little more and why we have to be careful about feeding these cats when they come into our hospital. Now, you got some time to read about this. When you're in practice, and you'll be like, hey, didn't Dr. Martin post an article for us? Did I download that? Let me go read that. Because the first day, the cat's not going to eat. And maybe not even the second or the third day. So you got a little time to work on that. But because of this, some of these cats, their liver is so inflamed and angry for such a long time that we actually end up placing feeding tubes in them. Because it may take weeks to even months before they actually start eating on their own. So I want to get enteral nutrition in them because that's what's best. So if I'm like, yo, I don't think this cat's going to eat for the next 3 weeks. By day 3, I'm like, all right, let's place a feeding tube, and this is how you're going to get nutrition until you can go to the food bowl and not hiss at it. So we can place E-tubes, we can place PEG tubes in their stomach, and give them a nice little low-profile one, give them a nice little sweater to wear at home. Some of our patients will, if their hepatic lipidosis isn't too terrible, if we're doing a good job of managing pain in the hospital and we give them good stinky food, they might actually go, hey, that smells kind of good. Maybe a little entice, something to stimulate their appetite. They may eat in the hospital. So we do want to give them the hepatic diets that are formulated for their condition. There are lots of them out there. Sometimes I will just give them something good and stinky that makes them go, hey, yeah, I kind of want to eat. And if I can get them eating something, then they'll probably continue eating whatever prescription diet I have in my hospital. And then if they are overweight, obese, we want to have that discussion about long-term dietary management with our clients once we send those patients home. The other thing we need to consider is cats need to have cat. So carnitine, arginine, and taurine, these are those essential amino acids that they may not either make on their own or they need to get from their diet. So if they're not eating meat, they're not getting these things. So we can add this as a supplement for these patients. We talked about appetite stimulants. Most of them are metabolized by the liver, so you might give them their appetite stimulant and then they sleep for 3 days. But then they'll be due for another appetite stimulant 3 days later, so as long as they're eating every 3 days. All right. If they have the transient diabetes, we need to manage that. For some of these patients, we will put them on an antibiotic, something to help reduce the gastric flora so that they're not continuing to produce ammonia. So while they may have some derangement of amino acids that are contributing to any hepatic encephalopathy that they have, they may also have a hyperammonemia component. So we don't want to forget about that part. So neomycin, lactulose. They're having a hepatic coma, cleansing enemas, followed by a retaining lactulose enema. All right, hepatic lipidoses. Any questions on hepatic lipidoses? All right, it's kind of fun to manage once you kind of have your like, okay, and this is what we're gonna do. But the first couple of times you're like, oh my gosh, kitty, please don't die. Don't die, kitty. Here's have more foods. All right. Other hepatopathies that we can see in cats. We can have a variety. We can have something that's suppurative, so we have neutrophilic inflammation along with a little bit of lymphoplasmacytic. You can just have lymphoplasmacytic by itself. We talked about triaditis with the GI tract, so our patients having pancreatitis, inflammatory bowel disease, and hepatitis. So this is where the hepatitis part comes in. We don't quite know why our patients develop a suppurative hepatitis. There are a couple of papers that have come out that we thought maybe there was some sort of ascending process through the biliary tree, and that doesn't quite hold well, so there's probably some other form of a bacterial translocation from whatever's sitting in the abdomen that gets cleaned up by the liver. We're still working on those mechanisms, but when we see the suppurative form, even if we don't see active bacteria or evidence of bacteria on our biopsies, these patients tend to be antibiotic responsive. So sometimes, if you're like, okay, I don't think this owner's going to let me get a biopsy, but let me give him a course of Clavamox and see if things get better. If patient responds to Clavamox, you go, oh, you're responding. Okay, here, have another 2 weeks of Clavamox, and then maybe another 2 weeks after we recheck you. And the hepatitis spontaneously resolves. And you say, okay, thank you, Jesus, and you keep moving. Some of them will be more chronic in nature, so they might have a relapse later on if their inflammatory bowel disease relapses or their pancreatitis relapses. Then we go, oh, you're back. Hey, let's try that course of Clavamox again and see if it works. Sometimes it will, sometimes it won't. When it doesn't, you're like, okay, we're going to have to go ahead and get a biopsy. With our lymphoplasmacytic ones, we need a biopsy. We need to know that there's lymphocyte infiltration because our treatment for those patients is going to be steroids. We also want to make sure they don't have lymphoma. So a biopsy is going to be necessary. All right. Where dogs get a hepatocellular type of liver cirrhosis, cats will develop a biliary cirrhosis. And so their liver just kind of shrinks down and the biliary tree just kind of gets gnarly and everything backs up. So if you get a biopsy of the liver and it comes back consistent with biliary cirrhosis for cats, that's going to be their end stage. So you talk to the owners about, maybe Fluffy isn't going to make it to this Christmas, but you might want to celebrate Christmas in October. Look, I have to make this funny because about half of my patients get some sort of disease process that's going to kill them. So, you got to keep it light. They're manageable diseases, but, it's like, okay, am I going to see you next summer or